Thank you for the invitation. Can you hear me? I can hear you.
Yes, we can hear you very well. Thank you.
Okay, fine. So I will start my presentation now. Okay, so thank you again for the kind invitation. And in the next minutes, I will talk about the current treatment options and the experience we have so far when treating adult SMA patients. And just to give you an overview, Essen is in the west of Germany, in the Ruhr area. It's a large conurban area, and we have a Center for Neuromuscular Disorders here at the university with a strong focus on motor neuron disease, especially on spinal muscular atrophy, and we are currently treating approximately 90 adult SMA patients and approximately 50 of them with nusinersen for several years since the approval of 2017. And I will now start with the overview of the adult SMA population. And first of all, it's important to mention or to talk about the natural history of adult SMA forms we have so far, but we know a lot about the disease course during infancy and early childhood, but the older the patients grow, the more scarce the data is on the adult situation. But it is important to mention and to emphasize that spinal muscular atrophy is a progressive disease course across all SMA types and across the whole lifespan. And this is something in which the data is only a very few. But when you look here at the figures from Wetman from 2018, you see here the MRC sum score and the median Hammersmith scale in the different age categories, and you see that when patients reach adulthood here with approximately 20 years, there is still a progressive disease course, a progressive decline in muscle strength, as well as a progressive decline in the Hammersmith scale with an estimated loss of 0.5 points per year in SMA type 2 and type 3 patients. So there is a clear need to address also this population with the current treatment options we have so far. And this is, again, a broad overview of the current treatment situation at a glance. So first of all, in 2017, we had the approval of nusinersen, with now more than 11,000 patients treated globally. It is approved for all SMA types, age, and conditions. But the situation from the pivotal studies was that there were no adult patients included, so we have no controlled data in the adult SMA population, but a growing number of real-world evidence studies. As you may know, it has to be administered via an intrathecal injection route, so in complicated spines, and especially in the severely affected adult SMA patients, you have typically a rotation of the spine, so you will be in need for using computer tomography guided injection, and this may be accompanied with a risk of radiation exposure. The second drug we have available for adult population, because I think onasemnogene, so Zolgensma, is currently not an option for adult patients, was risdiplam with the approval this year. And the main difference is that it is an oral medication. It crosses the blood-brain barrier because it is a small molecule, which is different from the antisense oligonucleotide. And the control studies included also adult patients. I will show you a slide on that later on. But all of these adult patients were non-ambulatory and below 25. So there is controlled data in adult patients, but this is also very limited. And we have no data for the ambulatory patients. And finally, as mentioned, the onasemnogene, the gene replacement therapy using the adeno-associated viral vector, which will be administered via a single intravenous injection. But there is no safety data in patients that were that weighed more than 13.5 a kilogram. And the second point is that possibly preformed antibodies against the adenovector may also interfere here with the efficacy of the drug, and possibly in older patients, Zolgensma may not cross the blood-brain barrier because it's much tighter in childhood and in adolescents and adult patients than it is during infancy. So for now, I think via the intravenous injection route, this is not that interesting than nusinersen or risdiplam. So we now come to the overview of the disease-modifying treatment options. And as already mentioned, the pivotal studies in nusinersen does not include adult patients. The oldest patients from the controlled studies were patients in the CHERISH trial. So there was a real need for looking at the efficacy in older patients. And the first study that has been prospectively designed, a prospective observational study, come from a German colleague of mine, Maggie Walter, from the University of Munich. And she, she followed 19 adult SMA type 3 patients for approximately 1 year, and 17 of those reached 300 days of treatment. And at each visit, she made a complete workup for the motor assessment. And in that small population, there was a significant increase of the revised in the revised upper limb module motor score. There was a significant increase in the walking distance with approximately 10 points. There was an increase, but it was not statistically significant, possibly due to the low number of patients in the Hammersmith. And which is also very interesting, there was a significant increase in the peak cuff flow, suggesting that also ventilatory muscle function may be improved by disease-modifying drugs. So this was the first and very important signal that nusinersen also works well in adult patients. And we also followed up our own patients and had also the feeling that there's real improvement. And that was the reason why we designed very early with the approval also prospective observational cohort study, but with a multi-center design. And we followed up patients for 14 months, and we included all adult patients with a 5q SMA with a minimum treatment duration of 6 months. And finally, we were able to recruit 173 patients, and you see that with ongoing treatment time, we were able to include 124 of them in the 6-month assessment, 92 of these patients in the 10-month assessment, and finally 57 patients reaches the 14-month assessment. There were only a minority of patients that withdraw from treatment, 2 for patients' wish and 2 for adverse events. And here you see the main outcome of our study, and we were very surprised that this underlines the efficacy in the adult population. We found at each time point a significant increase in Hammersmith scale, which was chosen as a primary objective, in the revised upper limb module, more focusing on the upper extremities, and in the ambulatory subpopulation in the 6-minute walk scale. And you see that after 14 months, we also reach with every scale the level of clinically meaningful change. This is considered when HFMSE increases more than 3 points, Rulm increases more than 1 point, and 6-minute walk test increases more than 30 meters. And here in the mean, we reached that after 14 months. So it is really an efficacious effect here in the adult population. And this is important for clinical practice, we see that the number of patients that reach a clinically meaningful change depends on the treatment time. So after 6 months, 28% of the patients had a clinically meaningful change. After 10 months, 35, and finally more than 40% reaches clinically meaningful changes. So it is important that there should be a minimum treatment time before you really judge on the efficacy of the drug. And we suggested a minimum of 1 year, better 2 years, to really get an idea if the drug makes a real improvement, or, and this is also an important goal, or a pure stabilization. But there were patients that improved more than others, so we were interested in a predictive subgroup analysis. So we defined 2 pre-planned analyses focusing on patients with and without a spondylolisthesis. Patients that were better at baseline with a cutoff of more than 35 on the Hammersmith scale and below. We focused in a post hoc subgroup analysis on patients that were ambulatory, and we looked at the SMA type and looked at SMA type 2 and type 3 patients. And you see that the better the patients are at baseline, the better the improvement is. So if patients are in a good motor condition, then the difference from baseline in the Hammersmith was 4.6. Patients without a spondylolisthesis improved better than patients with a spondylolisthesis. The ambulatory population, the same message. And finally, SMA type 3 patients improved more than SMA type 2 patients. So this underlines that starting treatment as early as possible is not focused on, or does not mean that treatment should be initiated on patient's age, but it should be initiated when patients are in a good motor condition. And patients in a good motor condition may really improve, while, and this is also important, the more severely affected patients may stabilize. And this is also an absolute important goal, keeping in mind my first slides, because SMA is a progressive disease over the years. But this was not the only, were not the only studies so far. Other studies have been published, especially this year. There is an increasing number of monocentric studies that all show stabilization or even improvement, suggesting that nusinersen is efficacious in the adult population. And there is another large population from the Italian study group with a retrospective design based on their registries. They followed 116 patients, also including SMA type 2 or type 3 patients with at least treatment time of 6 months. So you see that the design is similar, but here with that retrospective analysis, we have different baseline populations. There are some differences, but the main message is very similar. The better the patients are at baseline, the better the improvement is. So you see here on the right side the improvement on the Hammersmith scale in the walker population. You see the increase on the Hammersmith scale here within 14 months in the sitting SMA type 3 population, and you see here more stabilizing disease course in a SMA type 2 population. But it is important to mention that the SMA type 2 population in this study was only a few patients, with approximately 13 or 14 patients. The majority was suffering from a SMA type 3 with the 2 phenotypes of sitter or walker. So to conclude this, we think that nusinersen is an important and efficacious drug for also treatment in adult SMA population, and it is worth to try it. And it is also feasible, because we perform studies on our own here at the local center, how the feasibility rate is in using the CT guidance, even in patients with rotatory scoliosis, or even in patients with a spondylolisthesis. We were able to inject nusinersen in more than 95% of the patients. So it is absolutely feasible, even in the long run. But with ongoing treatment time, and in the next upcoming years, I think we have to consider also alternative treatment routes, because using CT guidance may be accompanied with a risk of radiation exposure. And with this, I will switch to risdiplam, also an interesting drug, because the main advantage is that it is an oral solution based on a daily intake. The mechanism of action is very similar to what nusinersen does, but this is a small molecule. So we have also SMN increasing effects in non-CNS tissue, like possibly the neuromuscular junction or other organs, because it is also important that we understand SMA as a more multisystemic disease than as a pure CNS or pure alpha motor neuron disorder, because SMN protein is ubiquitously expressed. So possibly we have to look at other disease manifestations in the ongoing years. So to look at the efficacy of risdiplam, the Sunfish trial was designed, and the Firefish trial have performed before, but Firefish focuses on infants and SMA type 1 patients, but the Sunfish study focused on SMA type 2 and type 3 patients, and patients were treated over 1 year with risdiplam. And here you've seen the main results. The difference, or the main difference to the nusinersen study, is that the primary objective was the outcome on the MFM32 scale. So this is maybe different from the Hammersmith scale, because the items were a little bit different, but you see that there were the results were in the same trend. So the study reaches its primary endpoint with an increase in motor function after 1 year of treatment. On the Hammersmith scale, it was not statistically significant, but possibly this is also depending on the situation at baseline, because in the Sunfish trials, patients were at baseline already much more affected than patients that enters the pivotal nusinersen study. So comparing both studies may be a little bit unfair. So we have no head-to-head comparison, but it's also not a good idea to compare these studies. We have to look at them separately. So risdiplam also has shown its efficacy, reaching its primary outcome measure, and we now have the data from 2-year observational period, because after 1 year, all patients that initially were treated with placebo were then switched to risdiplam. And you see that is a trend towards a further increase here in the revised upper limb module, and a trend towards a further improvement on the Hammersmith scale after 2 years. So you see that after 1 year of treatment, the situation stabilize or even improve, and this is also very important and a good signal. But this was now the situation in the overall population. So to look at adult population, it is more important to look at the different age group that have been examined in the Sunfish trial, and you see here the number of patients that undergo a clinically meaningful change. On the left side, the number in each figure in patients here in red that have been treated with risdiplam with a clinically meaningful change, and on the right side without a clinically meaningful change. And here in the lower right is the situation in the adult population of the Sunfish trial, but look at the very low number of patients. You see that the majority of patients were also children, but the population was between 18 and 25, and 22 of them were in this group, and the majority of patients stabilizes over the year, and only a minority improves, but all of these patients were not ambulatory. And when I would like to remind you on the results of our nusinersen observational study, we found that especially the ambulatory population has driven the score towards improvement. So we don't have now ideas how risdiplam works in adult population, if we have a similar efficacy or not. So this has to be examined so far. So to conclude this, which drug should we use for which patient? So for now, we have no data which compare the drug to each other. So comparing this is unfair. You have to make a very ideally shared decision based on the situation you have, if you were able to get a reimbursement for the drug. But we suggest treatment in all progressive disease forms, and in our experience, it is the majority of patients that is progressive over the years. The treatment goal depends on the prior motor situation. So patients that are already severely affected, we aim more on stabilization of the disease, while patients that are ideally still ambulatory, we aim to a real improvement in motor function. We think that treatment should be initiated as early as possible, but not on patients' age. Patients cannot be too old to get on treatment. This does not correlate with efficacy of the drugs. But for now, we have the most experience in adult patients with nusinersen. We have positive control data for risdiplam, but we will need further real-world evidence on that. And finally, the option you may choose depend on the patient's personal situation. And with it, I will give you here that last view on Essen and in industrial legacy. Thank you.
Спасибо.
Thank you, Tim, for your presentation, for this information, because I think it was very useful, and for us, very important to understand how to treat adult patients with SMA. This problem is acute. I would like to ask the audience to write down their questions. The first question. So, if you use a medication so the illness does not progress, is that true?
Yes, this is the idea, that we found as a minimum treatment goal a real stabilization and no further progress of the disease. But to reach that, it is important that when we initiate treatment is that we should wait long enough to really judge on the efficacy of the drug. Because in several patients, the progressive nature of the disease is very slow. And you have to ask some years ago if there is a really motor decline. When you ask patients, well, what about the last 6 months? The majority of patients say it's stable. But when you ask, well, what about the situation 3 or 5 years ago? Then patients say, well, this is a little bit different to now. And I think you have to treat long enough for a minimum of 1 or 2 years. And if you find a stabilization within a period of 1 or 2 or better 3 years, then it is a real drug effect, and the drug, it's worth that you treat further.
Thank you very much. The other question. It is written in English, and you can read it in our chat. I've been taking risdiplam for several months, and I felt great changes with my breathing and swallowing pretty fast, but no big changes with my motor function so far. How long should a patient take risdiplam to start having improvement in his or her mobility, for example, hands, fingers, etc.?
Yes, I would assume that the question comes from someone who is very severely affected, because there were already problems with breathing and swallowing, and this is also a very important treatment goal. We should focus everything about extremity function, bulbary function, or ventilatory function is also absolutely essential. But for looking at improvement at motor situation at the extremities, also or again, I think it should be treated with a minimum time of 1 or 2 years. But it may be that there will be no improvement with the extremities, because the disease may be still too long-standing, or the loss of motor neurons may be too extensive. But as you is already written in your question, there is already improvement on pulmonary function and ventilatory function, and this is also an important treatment goal. And this is not covered by the scores I have shown you. The Hammersmith scale, the revised upper limb module, they all exclude the pulmonary and the ventilatory system. And the more severely affected patients are, the more important this function is, and the more important is it to treat this function as well.
Thank you. There's another question. Data or the adult patients, according to Hammersmith scale and Rome scale, can this data serve as counter-indication for risdiplam? Can a doctor refuse to treat with risdiplam a patient if there are data of these scales, Rome and Hammersmith?
Well, it is, the scales we use, are scientific scales, and they are made to measure on a scientific level. But in patients' individual situation, these scales are not everything. They are a good measurement tool to get a broad idea, but several aspects of the disease and several functions are not covered. And as already mentioned, pulmonary function or ventilatory function is not covered, but may be of importance. And on the other hand, especially finger movement, which may be also very important to control the power chair, to control the mobile phone, and so on, is not very well covered by these scales. So it is important that you define individual treatment goals with the patients. You have to ask which goal you want to reach, which function you want to maintain, and then it is more controlling if this will be reached with a drug, because I don't think that there will be any patients who ask for, well, I would like to improve 3 points on the X or Y scale. Yeah, this is not the thing. This is more a measurement tool. Patients focus on function, and you have to ask for function and good idea on function. And I think with this, it's the best possibility to follow up on this and to give reason how the drug is of importance for these patients.
Thank you. There's another question. Thank you for this very informative presentation. Who chooses the medication? Can the doctor or the family change the medication? Can the caregiver suggest changing a medication? Can the family insist on medication change or on choosing two simultaneous different medications?
Well, there is no data for switching the drug, so we don't know if switching is a really good idea. If patients worsen under one treatment, even if you start with risdiplam or nusinersen, and the treatment time is long enough, so minimum 1 or 2 years, then switching the drug may be, well, it may be worth to think about it. But you don't know what happens. I don't think that it is a good idea to switch from nusinersen to risdiplam, because it seems that it is more easy in the usage, because it isn't. It is the intake is easy, absolutely true, but it's also a very active drug, which is first in class and have to be very closely monitored by the doctors, because it can have side effects we may know aware for now, and so on. So it is not easier, just the intake is easier. But I understand that patients ask for that, because getting the lumbar puncture is not a very comfortable situation. It is maybe accompanied with anxiety, with fear, with pain, and so on. But the message is, if patients are well on one drug, I don't think that then you should think about switching. Only when the situation is worsening, then there may be reason enough to switch, but for now there is no real good data. We know that switching is safe because there is some data from the jewelfish study on risdiplam, which focus on switchers, but we don't know how the efficacy is.
Thank you. Another question. What are the scales that you are using for patients with severe motor status? For example, difficult motor status in fingers. What scales do you use to assess them?
Yes, we use a subdomain of the MFM32 because the MFM32 scale that has been used in Risdiplam is separated into 3 domains, D1, 2, or 3. It is trunk motor function, gross motor function, and more fine motor function. So we focus here on the D3, but just to get a little bit feeling on that, how the situation is doing on the extremities, because on finger movement, because finger movement is very hard to measure. There are no standardized tools and no standardized function that can you really measure reliably. So this is a really important and interesting question, but for now, I don't have a clear advice to do it like this or like that. It is really very individually.
Thank you. Do you use electric myography with needles to assess change of neuromuscular apparatus while treating?
Yes, no, we don't use electromyography. We use the CMAP from the ulnar nerve, but only for scientific interest, because it does not we don't know if improvement here or if increasement of the amplitude includes is correlated with improvement on the motor function or motor scales. So I wouldn't suggest that you use it to monitor the efficacy of the drug in individual patients, because it is not sensitive enough. And the needle EMG, well, if you needle your patients every 4 months, they will deny it.
Thank you. Another question. Can we remove invasive ventilation of lungs with pathogenic therapy?
Well, for now, I wouldn't think that if a disease is in such an advanced stage that a permanent or long-term ventilation over the day is necessary, that patients won't get rid of that. It is the same with a milestone of the need to use a wheelchair. There are some barriers that we can get back through, because typically then the loss of motor neurons is too advanced, and none of the drugs will bring back the motor neurons. You can possibly improve the residual function of these neurons. You can possibly strengthen the synapses between the motor cells, but you won't get back that neurons. And this is the reason why we have to treat as early as possible. And as you may know, the most improvement will be found in pre-symptomatic patients. Yeah, if you have all your motor neurons, then you can freeze them in their current state, and then everything works fine. But in advanced disease stages, even the drugs we have so far are not that powerful to get back motor neurons.
Thank you. Another question from a patient. I'm 50 years old, type 3. I'm walking slowly. I got Spinraza, the first injection. After which injection will it be easy for me to walk?
Yes, the patients typically report or feel the first signs of improvement after 6 months. So I think after your 5th or 6th injection, you possibly may feel that there will be any improvement. That after the first 1 or 2 or 3 injections, there is that you won't feel any improvement. It does mean nothing. It's absolutely okay, because the system have to reestablish and to reunivate, let me say so, the motor neuronal situation. But I think there will be a minimum treatment time of 6 months, or better 1 year before the patient really sees his improvement. But you possibly may you may possibly experience some decline in fatigue, yeah, or something like that. That may be typically first signs of improvement, that fatigue will be reduced over the day. And this is something which occurs very, very early after initiating treatment.
Thank you. Another question. One of them, radioactivity and toxicity of medication. And the person who is under such a medication, is this person dangerous for others?
No. There is no transmission even when patients were treated with gene replacement therapy, because the vector or the viral vector that will be used cannot replicate by itself. It is some kind of dead virus, and the other drugs also does not move from one patient to another.
Thank you. Some more questions. What are the changes you can see with patients SMART-3 if they take risdiplam?
Yes, it is a little bit too early to give a real good overview, because we have risdiplam approved first in April, and the majority of patients that are now on risdiplam are more severely disabled because they waited for nusinersen, possibly to complicate spinal situation or something like that. But it's a little bit in the like in the early days when we initiated treatment with nusinersen. Patients feel that, patients show some signs of improvement, but to give a real hard overview on that, it is a little bit too early. I think I can in a year or 6 months I will have a better idea on that.
Thank you. We are waiting for these results. Pathogenetics treatment, and we see some improvement in motor functions. However, motor neurons cannot be resurrected. What is it connected to?
This is
what is the perspective?
Yeah, this is an interesting question, because this was the main concern, that the drugs won't work in adult patients, because as reported correctly, the motor neurons are away, so they can come back. But we will see that real improvement. So there will be any effects of the drug. And my personal theory is that SMN is expressed ubiquitously. It is possibly more correlated to the effects on other cells within the CNS, like astrocytes, which have more stabilizational functions on the surrounding motor neurons and so on. And I think possibly this may explain how patients improve when we reactivate the SMN protein in adults. Yeah.
Thank you. Another question. Risdiplam and Spinraza patient. The patient can breathe. How can we see the improvement in patients using risdiplam or Spinraza if they don't have movement in extremity muscles? However, they can breathe independently.
Then we have to define what the treatment goal is, because if a patient is mechanically ventilated 24 hours and there is no movement of the fingers or the extremities at all, then this may be one of the situations in which I recommend not to use one of the drugs, because then there will be no possibly outcome because the patients are then also still ventilated for the whole day, and then it is not very realistic that there will be any improvement. The problem will then that patients have to deal with additional side effects, and this may result in another problems. But this is the maximum disease severity in the stages before, in which possibly there is residual finger movement or something like that. Then you have to look very closely on the patients, and not only on movement, but more on the function. For what is the movement essential? And if it's something like controlling power chair, or is it something like controlling mobile phone, then this will be your treatment goal.
Спасибо. Были ли
Another question.
Были ли ухудшения состояния?
Have you observed deterioration in patients with SMA?
Under treatment? I would assume under treatment.
The question, have you seen deterioration in adult patients with risdiplam, with Spinraza?
Well,
have you considered any deteriorations?
Yes, we have, but in a minority of patients. But there are some patients that worsen even under treatment. Yeah, but the majority of patients experience stabilization or improvement. For the observational period we have so far, we don't know how the situation may be in the next 3 or 5 years, but so far we found deterioration only in a minority of patients. So there are some non-responders.
Thank you. And there's another question. The patient can't move. The patient can't move his or her extremities, but can breathe independently. The patient can breathe, can eat independently. However, the movement is very weak. What are the improvements that we can expect with pathogenic treatment?
Yes, the treatment goal then will possibly be to stabilize that the patient will be possible to eat by himself, to breathe by himself, to eat by himself. Yeah? And this is a realistic goal, that you want to prevent the patient from further deterioration, to get loss of the swallowing ability and so on. Yeah.
Thank you. Another question from a patient. I take risdiplam for 1 year. I have improvement, but I have swallowing in legs. I used to have them before, but now the swallowing or edema persists. Why does this edema doesn't go away? I do take risdiplam.
We don't know, possibly that can be a side effect of risdiplam, because risdiplam in comparison to nusinersen has systemic effects. This may be of advantage or this may be of disadvantage. So we also have to look at other reasons for swelling of leg, like problems with the heart and so on, but it can also be an adverse event of the drug, side effect of the drug. This has to be checked. Yeah.
Thank you. There's another question. It's in English. It's in the chat.
Yeah.
I've been taking risdiplam right now. What if I'd like to have a baby? We do not know whether it's a lady speaking or a gentleman. Can I switch to Spinraza, or do I have to stop my treatment completely?
Well, risdiplam has to be stopped completely in male as in female patients, because there are signs that there will be problems with the baby in the early phase. So risdiplam has to be absolutely stopped. Taking Spinraza, well, from the prescription information, there is written that there is no information what about pregnancy during nusinersen. So we don't have data on that. But more from the theoretically side, you may assume that the baby will get not in contact with nusinersen if you inject that intrathecal route. But this is not a suggestion then to switch. You have to very closely monitor the patient. Ideally, patients or female or women should get pregnant without a drug. And if family planning starts, then you should stop the drugs and close them and monitor them very closely. And if during pregnancy there is a worsening of motor function, then you have to choose a very individual situation. But for now, there is no data on or no systematic data on pregnancy under one of these drugs. But risdiplam may be more problematically than nusinersen.
Спасибо большое. У нас на самом деле еще огромное
Thank you very much. We have very many questions so far, and
у нас, к сожалению, уже
unfortunately, we don't have enough time to answer them, to ask them. We need to go on, and I would like to thank you for being with us today. Thank you for your presentation, and I hope to see you again. Thank you for your experience, and I hope to see you next year with much more information about these medications. Thank you. Goodbye.
Thank you for the invitation. Yeah, bye.